Well, and it's an honor to be here with you. So, the first slide, please. Let patients help. This has become my slogan, and I'll tell you a little bit about that. And there's this logo of the Society for Participatory Medicine, which you heard a little bit about. I'll be explaining where that came from. It is the most unlikely thing in the world that I, a random guy from Nashua, New Hampshire, would be traveling around giving speeches about the future of medicine. I'll be explaining how this happened and what I see that has led this to happen. In the process of doing this, I encountered this badge, which you folks are using. Not only are you using the badge, you are earning it better than anyone else, any other event I've been to. In fact, just today on Twitter, there was a discussion about, well, but how much are you including patients? And in fact, the guy in Holland who came up with this now is proposing a 5-star rating system to grade just how much a conference is including patients. And this conference will be pretty far up there, no question about it. Now, how did I get to be here? Well, I worked in high-tech marketing, mostly graphic arts. And some of you may remember typesetting machines. Well, I used to run typesetting machines, and then I used to market typesetting machines and work in product management and so on. That is an industry that got radically redone from top to bottom, inside out, when desktop publishing came along. Once that industry got computerized, new things became possible. It used to be that you could only do typesetting if you had access to fonts. And you could only have fonts if you had a typesetting machine. And if you had a typesetting machine, you needed to have a typesetting terminal, and on and on and on and on. The industry got busted apart. Now, all of you have fonts on your computer, and some of you have fonts on your phone. And the typesetting industry, where I used to be an expert, doesn't exist anymore. And those of us who were excellent at that have been called on to be excellent in a new way. This is what happens when industries change. If you live long enough, the industry where you work is going to change. We've got to adjust, all of us. Well, I am a data geek. I love Excel. I do unnatural acts with Microsoft Excel. I do pivot tables and graphs and things that other people can't do. And it turns out that's important as we start to computerize our medical records, because when you work with data, as I'm sure some of you do in your day job, you learn that if the data is bad, the computer spits out garbage. All right? And as we computerize our medical records, everywhere I go, it turns out there are lots of mistakes in the chart. And if nobody ever goes back and looks at the chart, it doesn't matter. Surprise, surprise, guess what? A lot of charts don't really get looked at, but when you put it in the computer and it's present, that's an issue. So bear that in mind as we move forward. In 2007, I discovered I had cancer and I was almost dead, and I got better. You'll be hearing that story. I really did. I was diagnosed in January, and my treatment ended in July, and I'm all better. So, I love good medicine. Some people think patient empowerment is anti-establishment, anti-medicine. No. It's a matter of partnership, as we'll be discussing. 2008, I became a blogger in the e-patient movement, which I'll explain. In 2009, this Society for Participatory Medicine was formed, and I started giving speeches. It was very much an Alice in Wonderland sort of experience, like I was tumbling down the rabbit hole thinking I was dying with cancer. I went boomf, hit hard, and a year later, the lights came on and they gave me a microphone and started asking me to give speeches. It's just very strange. If I had told anybody that I had this as an objective, as a plan, people would have been justified in telling me I'd been smoking too much wacky weed. But it happened. So, and in 2010, I felt a calling. I started doing it full time. And in 2011, it went international, and this is what I'm doing now. It's been hard, honestly, because when I started doing this, as I say, I felt this calling. I've had good jobs in my life, but this is the first time I've ever felt that I had a reason to be alive, something that I felt called to do. And nobody in those days had any thought, they just thought it was crazy to think of paying a patient to speak at a conference, a medical conference. What, you're not a doctor? And it took me 3 years of hand to mouth. I finally reached break even in November. So now I finally can look forward to building a new future. Now, I'm going to give you a little bit of history, and those of you who've been paying attention to Twitter may have some idea of what's coming up here. But in 1969, this happened. Humanity landed on the moon for the first time. This was the first time that speck there in the distance is Earth, the first time it had ever been seen from another surface. A few weeks later, Woodstock happened. Wow, what a summer that was. I was 19. Woohoo! And I was a college student in Boston, and it was a great time to be 19. And everything we always thought was not possible was becoming possible. 300,000 people having a party on a farm and go to the moon and everything. Well, at that time, there was a guy who lived down the hall from me in the dorm. We went to MIT, and years later, I found out that he had become, we double dated when we were 19, and then I found out years later he'd become the CEO of this hospital in Boston called Beth Israel Deaconess. It was Paul Levy, who some of you may recognize. And he made me swear that I would not tell any stories about what happened back then. And that's kind of a little bit of reverse psychology, because if there were any dangerous stories to be told, they would be about me. But anyway, this picture was taken 3 years ago with a gathering of patients at a marketing conference, but it was a dinner attached to the Lean workshop that Beth Israel Deaconess was running, and that was my first exposure to Lean. I was invited in, as many of you are, as the voice of the patient, so that the people doing the redesign work could turn and ask patients, well, what do you think? Is this how you would want it? So this work continues, and it's a pleasure to be involved. Also at Beth Israel Deaconess, years ago, these two doctors have been saying since the 1970s, the resource that's most often underutilized is patients. The one on the right, Warner Slack, is a senior physician, and he's been working on electronic medical records literally since the 1970s. And his protege there, Charlie Safran on the left, this is a quote from when he testified to Congress, and they have seen for ages that patients are capable of participating in medicine. My hospital was one of the first in the 1990s to have a patient portal. And in fact, when I was shopping for a new doctor in 2003, I had just heard that Paul Levy, who I hadn't seen for decades, was the CEO of the hospital. I said, do you guys have primary physicians? He said, yes, you'll like this guy. And he introduced me to Dr. Danny Sands, who you'll be hearing more about, who co-created that patient portal back in the 1990s. So I didn't just fall into being involved with this kind of hospital. It was because I was actively searching for what I wanted. Now, some foundation principles here before I get started, because the excellent presentations that I've heard here, particularly Helen's yesterday and Dr. James this morning, this is earth-shaking stuff. You have to understand the foundation principles that underlie all of reality. It's sort of like physics. If you don't understand the laws of nature, you are not going to understand what's changing and what's not. Okay, so one of my foundation principles, patient is not a third-person word. Now, as far as I can tell, this lesson is not so necessary here as it is in a lot of places. Your time will come. The very first health policy meeting I ever attended, out of nowhere, I noticed everybody was talking about patients as if it was somebody out there on the street, not somebody in the room. So this one I think is pretty well understood. If it hasn't dawned on you, though, please know that my story that you'll hear here will be coming to your breakfast table, and everything looks different when you get that. Second, patients are the ultimate stakeholder, and yet they're often omitted from planning the future. Again, Saskatchewan, did I say that okay? Do I get free drinks tonight? Good. I wanted to ask Helen last night, so which of the 5 energies does that feed into? That's social, I guess. There we go. Anyway, and here's a pivotal force. Remember, I worked in high-tech marketing. There are lots of new ideas that come along. Some of them get traction and grow and change the world, and others don't. So you learn to look for what are the things that come along that make an idea take off. In desktop publishing, believe it or not, it was the ability to publish our own newsletters. Now, that was a weird thing because there was no huge community of people sitting around saying, man, I wish I could publish my own newsletter. And yet when the Mac came out in PageMaker, people started doing it. So you've got to not get too arrogant about your own view of the world. Watch what people want, okay? And here in medicine, there are plenty of people who say, well, Dave, you know, I'm not so sure you really need to be asking questions of your doctors or getting copies of your medical record. But nobody ever says that to the parent of a sick kid. Nobody ever says, it's none of your business, okay? And often, if it's a sandwich generation person taking care of their elder, providers in my experience are more likely to say, go ahead, sure, here's the information. Well, to return to this, shortly after this, that same summer, the Whole Earth catalog came out. This was a post-Woodstock hippie survival journal, which was about how to be, it wasn't hippie in the sense of hedonism, it was how to grow your own food, build your own house, be responsible for yourself. And in the 1980s, a young doctor out of Yale named Tom Ferguson was the medical editor of the Whole Earth catalog. And he said, he pretty much saw things the way Dr. Spock did. The first words of Dr. Spock's baby book were, trust yourself, you know more than you think. Now that was in the 1940s, all right? And yet he was excoriated at the time. Tom Ferguson was excoriated. People saying, what are you doing? Telling people they don't need so many doctor appointments. Well, Ferguson published a magazine and then a book called Medical Self-Care, about the reality that we take care of ourselves and our families pretty much. But he also saw that when you get really sick, there's a big limit to how much you can do to take care of yourself, and a lot of that limit has to do with access to information. So when the internet came along, he saw that new things became possible. Now, my wording on this is important. I'm not saying that all of a sudden everybody's a surgeon. Okay, new things become possible. We still have to figure out how to make it work. And so then he predicted that with access to information, all kinds of new things would be observed, and he started spotting people in the wild who were doing this. The guy on the left is named Gilles Friedman, and he founded the network of cancer patient email groups that I eventually joined. Next to him are Alan and Cheryl Green. He's a pediatrician. They formed the first physician website recognized by the AMA in the early 1990s, or the mid-1990s. The good-looking guy in the middle is that Danny Sands. So this circle of people that Tom Ferguson spotted, Danny Sands wrote the first guidelines on how to use doctor-patient email effectively, published them in 1998. That was 15 years ago. Does your doctor happily email you? Some do, some don't. Anyway, that's the group that I stumbled into when I asked Paul Levy if they had primary physicians. And Ferguson had this term e-patients, equipped, engaged, empowered, enabled. Now, when he died, he was working on a manifesto, a 120-page paper, funded by the Robert Wood Johnson Foundation. That gang in 2009 decided the time had come to stop being a little hobby club, and they formed this society. That's Dr. Sands and me with an actual computer in the exam room. Notice how he has the computer turned so we can both see it. His view has always been that the medical record is a shared document between the patient and the provider. Okay, and we'll be talking more about that later. Now, that when they formed this society, they said, well, it won't do to have this medical society just be run by doctors. It's got to be run by a doctor and a patient. And to my amazement, I mean, I was just a year and a half out of cancer, they elected him and me as co-chairs of the medical society. So I went from being almost dead in 2007 to being chairman of a medical society in 2009. It's a pretty good trick. Some people call it the jiu-jitsu approach to cancer. Use the energy of the attacker to propel yourself forward. Well, Health Leaders magazine goes to about 100,000 hospital executives in the US, and they got wind of this, and they came and interviewed Dr. Sands and me and a bunch of other people. And much to our surprise, they made this a cover story. So you can sense my life is starting to spin out of control. What the heck is going on here? they made it a cover story, and they called it the patient of the future. Now, I would not have been audacious enough to say, yo, I am the patient of the future. Right? You down with that? Well, they did. In fact, they sent a photographer, and I figured it was going to be the usual, just take a picture of your face and put it in the column of type. Well, quite honestly, I would have worn a different shirt if I'd known they were going to do this. The full page on the table of contents. Isn't that lovely? Now, the interesting thing here is you can tell this was not set up by a PR agency. Okay? This was the editors of this magazine saying there's something going on here and making a cover story out of it for hospital executives, saying this is the patient of the future, a middle-aged schlump in a bad shirt and shorts looking stuff up on the internet. All right? Deal with it. And then the circled thing on the cover on the left, they really did a superb job of getting it right. It's not about the patient doing new things. It's not about the doctor doing new things. It says a new relationship. It's about the altered relationship. Sometimes we talk about it as new dancing lessons. In the old days, when I took dancing lessons in first grade, the boy led and the girl followed, right? Well, not so much anymore. Okay? And that's now, what's important here is that both parties need new dancing lessons, okay? Having permission to do something doesn't make you an expert. We still have to learn how to do it. And the best way to do it, as with any other partnership, is by talking with each other. I was at an event last May in Maine where Richard Rockefeller, who was a friend of Ferguson and a primary physician, he said, well, if you have a collegial relationship with your patient, you can talk about things, right? Like colleagues. Amazing, wonderful thing. Well, every year in December, this magazine runs a feature called 20 People Who Make Healthcare Better. Number one on the list that year was Atul Gawande, who is this fabulous surgeon who writes incredible essays, just such a good storyteller and so top-notch clinically, professionally. No question, he deserves to be number one on that list. Number two was Dean Kaman. He's the inventor of the Segway scooter. Well, his clever company now is making amazing robotic limbs for amputees that I've seen some of them demonstrated. Unbelievable, the things that some of these can do. Imagine my surprise when number three on the list was me in that stupid shirt. So you can see the Alice in Wonderland thing. What is going on here? I said, guys, couldn't you have told me you were going to do this? We could do another photo shoot. Importantly, number four was Dr. Sands. What they were saying 4 years ago, 2009, was that this doctor-patient relationship was right there on the same page with Atul Gawande and Dean Kamen as one of the most important things happening in medicine. Now, I'm really saying, what is this? But you can see I was feeling the calling as well. In high tech, as I said, there are a lot of things that turn out to be a flash in the pan. You may recall years ago, everybody knows how the iPad has changed the world. Well, years ago, there was a thing that Apple came out with called the Newton, which really did not change the world much at all. And yet there was just as much buzz about it at first. And when the iPad was new, about a third of the blog posts and reviews said things like, why can't Apple do anything right anymore? Even if you are an industry observer, it's hard to tell. What is there, and is there a there, as people say? So I looked around for evidence because, see, in my career in marketing, you got no points for being smart and nobody wanting any, okay? But this is a problem we have in medicine sometimes. So you think, well, I'm good, or I published a paper, my work is done. If the world doesn't change, that's their problem. Well, when you're on the patient end, it looks different, right? So I asked, well, who's getting online? I've been online since 1989 on CompuServe. Back when you had to have a phone modem and you paid by the hour and you paid more per hour depending on how fast your phone modem was. I had a big phone bill, let me tell you. I'm a chatty guy. Now, that was 20 years ago. 20 years later, the Pew Internet and American Life Project said 83% of US adults were online, okay? So by that one metric, what this little monopoly piece was doing 20 years ago was a predictor of the future. Now, that's just one data point. You can go out of business trusting one data point, so I looked for another one. I said, well, what else have I done and I thought, well, romancing online. I met my wife on the internet in 1999 on Match.com. And it was amazing. I mean, she lived 12 miles away from me, and I didn't know she existed. And the terrible things about life, I gave lots of speeches in my professional career, which has turned out to be useful later. Well, a year after I met Ginny, I had to go give a speech in Paris. Oh, darn, about data, of all things. So we got hitched, and there she is on top of the Impressionist Museum in Paris. We made a honeymoon in Paris out of it. Well, 10 years later, 1 in 8 weddings in the US were people who met online. All right? What's possible to connect with what you're looking for is different from because of the internet. And in fact, in 2011, it's up to 1 in 5 couples, that's not weddings, but couples, are people who met online. Now, if you think of somebody like Ginny and me, that may seem a little hard to believe, but when you think about 20-somethings on Facebook, okay, it's not hard to believe at all. So here's a glimpse of how the world has changed. Now let's move forward into my story. I was an engaged patient before I ever heard the term. Okay, so I had moved away from the Boston area for a few years, and in 2006 I was moving back. And I wrote to Dr. Sands and I said, I'm coming back, will you take me back? He said, yes, I've got space. And so as we approached my annual physical in December, I had a bunch of things I wanted to talk to him about, so I sent him an agenda email. Some people say, you did what? Dr. Sands says he's glad I did because he had things he wanted to talk about too. And think about it, in any other area of life, if you're going to see somebody expensive that you don't see very often, do you wait till you get there? You say in advance what you're taking the car in for, whether it's a flat tire, an oil change, or a transmission repair, Well, so here's how this worked out. Consider this. I had a weird thing going on in my right eye. Sometime around October, I'd had this dazzling, sparkling spot start in my eye, and after a bit, it got bigger, and it turns out it was boomerang-shaped, and it got bigger and bigger and bigger, and after a half an hour, it had outgrown the eye, and it was gone, and I thought, whoa, flashback. The second time it happened, I didn't think that. I thought, what was that? And the third time it happened, I started taking notes. Now, obviously, I wanted to talk to my doctor about this, but did I wait until I got there? No. I didn't want to spend the time I just spent with you in my precious minutes with him. So I went out and Googled. I Googled, right? And I found a picture of what it looks like, and I pasted it into the email. All right? I said, I've got this happening. And I pasted in the URL, the website, so he could go look at it and say, good site, bad site. And people say patients should not diagnose themselves on the internet. Well, how am I going to diagnose myself? This was a website about ophthalmic migraine, so I pasted that in with a question mark. See, the hallmark of participatory medicine is the engaged patient doing everything they can to communicate with their physician, right, and saying, what do you think? Here's what I found. What do you think? This is no insult to the physician. We'll get back to that later also. And I also pasted in my little diary of episodes. Now, another thing, as it turns out, we got this resolved before the visit. Isn't that interesting? I also had a stiff shoulder. Now, instead, it wasn't really painful, but instead of reaching up like this, I'd rather do this, that kind of thing. And I said, I don't want to wait 3 months for your stupid referral delays, which sometimes happens, so please get me an appointment with an orthopedist, and he did. So we had our visit on December 29th. I went away for New Year's weekend, came back on January 2nd, had the visit with the orthopedist. What happened next is one of these moments that if you've ever been through it, you know what I mean, is burned in my mind. I have complete multisensory recall of the moment when I got this news. 9 a.m. sharp, January 3rd, 2007. I'm sitting at work. The color of the wood on the desk was a little bit lighter than this. I had bright blue carpet on the cubicle partitions. I remember what the Sony phone looked like on the desk. And it rang, and he said, Dave, the orthopedist called me, or the radiologist called me, and I pulled up the image on my screen at home. And I thought, I'd like to pull up the image on my screen so I can see what you're talking about. And he said, Dave, your shoulder's going to be fine, but there's something in your lung. And that spot was not supposed to be there. He said, we don't know what it is. Could be some fungal thing or a scar from some old infection. And I said, but you need me to get back in there? He said, yeah, we need to find out what it is. We talked a few minutes more, and at the end of the call, I said, so is there anything I should do? I was thinking stupid stuff like change my diet, get more sleep or something. And what he said was, just go home and have a glass of wine with your wife. That was a signal. He said he wouldn't do that with every patient, but he knows me well enough that he was able to do that. I went in for a CAT scan. That golf ball size thing is a different tumor in the other lung. Turned out I had 5 of them. At that point, we knew it was cancer that had spread from somewhere else, because lung cancer doesn't look like that. So I'm sitting there, and I don't feel sick, and they're telling me I've got tumors all through my lungs. It's like, why doesn't something hurt? What's going on here? And he said, usually, something like this is blood-borne from an abdominal organ. A piece breaks off and goes circulating, and at some point, the heart pumps it into a tight spot in the lungs, and it just gets stuck and starts growing. I had 5 of these, and they'd been growing for a long time. We had to find out where it's from. My wife came along with me for the ultrasound. I got to do the jelly on the belly thing, right? She's a veterinarian. She knows I'm not a dog, but she's seen lots of ultrasounds. And this is from a later MRI. That's one of my 2 primary tumors in the right kidney. This had erupted from the front and was beginning to touch on the bowel in the area. There was another one that had erupted out of the back and was beginning to connect. It's just beginning to touch the psoas muscle, but had not invaded yet. So now we knew, we didn't have a biopsy, but we pretty much knew I had kidney cancer. Some people say, stay off the internet, you'll scare yourself. Well, are you kidding me? Now, I know some people don't want to know. That's fine with me. Some people just want to say, oh my God, take care of me. Do whatever you have to do. That's fine with me. But if somebody wants to understand what's happening to their body, let's let them learn to do it better. I went to WebMD, which as a first pass was a reasonable place to go. At least it wasn't something selling Laetrile, right? And what I found, get this, the prognosis for any progressing disease is poor. Almost all patients are incurable. That's a heck of a thing to read. People say you'll scare yourself. Well, I was going to get scared when I heard that from somebody. And I've been Googling since before there was Google. People say, don't Google because you'll get stupid advice and you'll get in trouble. Well, you know what? Before I met Ginny on Match.com, I went through some suboptimal search results, but I didn't marry the first one I found. Why do we think people are more stupid in medicine than they are in other areas of life? Well, I went to every page I found, every article I found said prognosis is bleak. Outlook is grim. And I'm thinking, I don't even feel sick. I've been getting tired in the evening, but I'm 56 years old. My appetite's been dwindling, but I figure I'm just slowing down until my weight's been dropping slowly. But for me, that was a victory. The doctor had been telling me to lose weight, right? Well, here is a diagram of stage 4 kidney cancer from the website of the drug that I eventually got, high-dosage interleukin. Totally by coincidence, there's that thing in my lung. I'm a poster child. If you look at the femur on the other side, my first symptom I had was 6 weeks later, my legs started hurting. I said to people, boy, I wish I could go back to where all I had was cancer. Well, careful what you wish for. I had a big metastasis in that bone. And if you have not personally experienced what they call bone mets, let me tell you, it is pain. It hurts a lot. It gets your attention, nature's way of saying something's wrong here. In fact, one morning that May, I got up at 5 in the morning to go to the bathroom, and I felt dizzy. I called out to my wife and fainted, and when I woke up, I landed on the femur, and it was shaped like this. Here's a safety tip. If you're going to break your leg, pass out first, because I had no pain. By the time I woke up, I was in shock. It's a good trick, and by the time the shock wore off, the medics gave me morphine. And, I just want to say, that's that leg. look what I can do. I mean, my balance is no better than it ever was, but I am fixed, you know? Yo! You know, and the repair actually failed, and we did it again. But you know what? You go on and say, okay, what's next? Come on, life, bring it. You know, I am repaired. Well, and I had, since I'm an overachiever, see, there's that one in the head. I had one in the skull, although that shows the brain. I had extra ones scattered throughout the body. And 3 weeks before my treatment started in April, in the middle of March, I had what I thought was a cold sore in my tongue. Look at the head again. I had a kidney cancer tumor growing out of my tongue muscle in my mouth. As you may know, only the most aggressive cancers grow in muscle tissue. I was wicked sick, as we say in Boston. And my median survival was 24 weeks. All those factors like fatigue, dwindling appetite, and so on, all counted against me. Well, when I realized that, I woke up at 1 o'clock in the morning that night, and I vividly recalled what the ceiling in my bedroom looked like as I realized, what am I doing sleeping? It's over. My life is ending now. I thought, holy crap, 24 weeks. This is just, that would be June 25th. I knew enough about statistics from college to, I mean, my mind's racing, right? To know the median isn't the absolute number. It only tells you where the middle person in the study died. But so like maybe I'll live a few more months. Maybe it'll be September. Is it going to be a fall day when I look out the window for the last time? Am I going to see autumn colors the last time I draw a breath? It's vivid. What can I say? I thought about my mom. A year and a half earlier, we had buried my dad. I remembered her face. I thought, what's she going to look like when she buries her son? I had to sit down. As you know, families have to do this together. Sat down with my daughter, who had just gotten out of college, and her boyfriend, and said, here's the news. This doesn't look good. But here's what we're going to do. We're going to do everything possible. And at the end, I said, just one last thing. I don't want you guys to do anything stupid. Don't get married prematurely just so you can do it while Dad's still alive. We're going to work on this. So then we get to work. What are the options? Some people, as I said, just want to say, fix me, take care of me, I'm scared. I wanted to know, what are my options? You know, you may have seen a long time ago, there was this cartoon of a frog being swallowed by a stork. And even as the frog was being swallowed, his arms were out there choking the stork's neck, like, I'll do anything I can. Well, that was me. In my case, I chose to get engaged, get in gear, do everything I could. First thing, my doctor, once the biopsy confirmed it, my doctor referred me to a patient community on the internet. He knew this guy, Gilles Friedman, who had started this network of cancer patient communities. And he said, Dave, you're an online kind of guy. You might want to do this. Well, I used my CompuServe skills. I watched the activity in that email group for a couple of days, and then I spoke up. Look at this. Within the first 2 hours after I posted a note on Alivecor, they told me, this is an uncommon disease, get to a hospital, does a lot of cases. There's no cure, but high-dosage interleukin-2 sometimes works. And when it does, about half the time, it's permanent. Voila! Complete and permanent. But the side effects are severe. They sometimes kill patients, so you have to get to a specialist center. In my case, my treatment was discontinued at one point because my blood pressure had dropped to 50/30 because of capillary leak syndrome. The capillary walls had opened up, all the fluid had gone out, my legs blew up like water balloons. Severe stuff. Don't let them give you anything else first. This is not documented in the literature anywhere, but my oncologist says it's correct, okay? Because if you do, it reduces the chances that interleukin will work. Nobody knows why. And here are 4 doctors in your area who do it, and their phone numbers. Now, is that useful information? And here we are, 6 years later, there is not a single medical website that gives patients this information. Now notice, this does not invalidate what's in the literature, it adds to what's in the literature. You will not find, you look at the Kidney Cancer Association, the American Cancer Society, anything like that. Kidney Cancer of Canada actually has better information than the American Cancer Society does. Next thing I did was reading and sharing my hospital data online. It's this clunky, old, ugly patient portal, but I wanted to know as much as I could. People say, well, patients can't understand this. Well, you know what? I have medically knowledgeable family and friends. I don't live in a vacuum. My sister's a physical therapist. My wife, as I say, is a veterinarian. My best friend, who lives in Tel Aviv, has a brother who's a top doctor. People can connect through their social networks to get information. Another thing I did was I joined Caring Bridge, which is it's like a simplified blog, so you don't have to make the same phone call to 20 people every time there's news. You post it, and anybody who's signed up gets an email. This is free. This is really useful. You know, an amazing thing happened here because my support went viral. People took these notification emails and sent them to friends. So I started to hear from people, get notes of support from people who I hadn't seen for years. Then it eventually went to where I got notes from people I hadn't seen since college, and then eventually high school, since I was a teenager. And let me tell you, when you are wondering whether the universe is done with you, and people start coming out of the woodwork and cheering for you, it makes a difference. I'll tell you, it was really something. Well, me being me, I got out Excel. Now, we're all looking for the day when we'll have pretty graphing software for our medical records. Well, I did what I could. So this is the guy who 20 years ago was on CompuServe, right? And I looked up the tumor sizes in the radiology charts, and I started keeping track of them as the treatment started. And when the numbers dropped, it was like, woohoo, because with interleukin, either you're a responder or you're not. Well, long story short, 5.5-hour laparoscopic surgery and interleukin treatment, and there's that same tumor 50 weeks later. They never had to cut me open except to remove the kidney. The interleukin just killed all the tumors in the bones and everything from inside. The immune system, man, when we learn to harness that thing, it's going to be incredible. And here's how it all worked out over the course of the years. Between the yellow bands show the 2 months of interleukin that I got, and notice how the stuff dropped like crazy in the 2 months in between. It's funny, I stopped keeping track at this point because the remaining spots inside me, which we presume are scars, they got too small to measure in both dimensions. And the nurse practitioner said to me on the visit in September 2009, you know, it's no fun with you. I said, what do you mean? She said, well, with most patients, I've got to look at the numbers, figure out what I'm going to say to them, because different people have different appetites for information and everything. With you got a CD on your way out of the building. On the bus home, you stuck it in your computer and popped open your DICOM viewer. You already know what the answer is. I said, how'd you know that? She said, you posted it on Facebook. So look what's different. Okay. Could you stop shuffling silverware back there? Thank you. This is an empowered person speaking up, right? An empowered person knows what they want and expresses it. And I didn't yell, I didn't complain, I just said, could you, right? There we go. Those of you who have been through the women's movement and learned how to be empowered women may find some familiarity with this. Well, so now here's a question, okay? I am an MIT graduate. I understand the scientific method, all right? I am not anti-science. So how can it be that the most useful and relevant and up-to-the-minute information could possibly exist outside of medical journals? How could that be? Well, Ferguson, when he died, was working on this 120-page paper, which is a free download on ePatients.net now, which is the blog of the society. And in the process of working on this, he talked to Donald Lindbergh, the director of the National Library of Medicine. Now, I often find that people in the medical establishment will resist assertions that are demonstrably true if they don't come from someone higher in the hierarchy. Well, Donald Lindbergh, you want to go argue with him? Now, I've been to the National Library of Medicine. It's a big place. They take in all the journals. And he said that when he was a young doctor, he was told that a good doctor would go home and read 2 journal articles every night to keep up on things. He said, if I did that today, at the end of a year, I'd be 400 years behind. It's just too much for anybody to know everything anymore. It's not humanly possible. And it turns out, I did the math, that was 10 years ago. So it's much worse than that now. Then there's the lethal lag time. This is publication delay. There is a moment in every clinical trial or any kind of research where the principal investigator says, you know what, we're going to be able to publish this. Between that moment, at that moment, that knowledge has come into existence in humanity. And the time that it goes through publication, writing, peer review, and everything and reaches your doctor is 2 to 5 years. Now, if you have a median survival of 24 weeks, or your daughter does, or your mother does, whatever, this is a problem. The idea that knowledge could have been out there for a year and not made it to the doctor's desk yet. Okay, so what you find in a community like ACOR is that patients are scouring the earth, looking not just for papers that are in publication, but research that is in process, that may be far from publication. I knew a woman named Judy Fetter, a metastatic breast cancer patient, who found a researcher working in some obscure lab on an obscure biological marker. They'd exhausted every other pathway, various treatments and so on, and she brought it to her oncologist. Again, this is the participatory approach. She didn't say, hey, stupid, why didn't you know this? She said, I found this, what do you think? And in partnership, he looked at it and said, that looks interesting. They tested her. For her, it worked. They had to concoct an experimental thing. But she ended up getting 18 more months of watching her grandchildren grow up. For her, that's what was important. That's what was valuable. Equally important to her was that her grandchildren got another 18 months of living with her before she passed. And you know, in internet terms, we talk about this as latency. You click on a website and it goes spin, 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 and the information doesn't come to you. It's out there, but it's latent. Well, same things here with medical research, it turns out. What's happened here is because of the web, because of the web, patients are able to connect in ways that were not possible before the web. All right, now this is a common generic network diagram, but I've come to think of those dotted lines as being like capillaries. Okay, if you think of information as a nutrient in medicine, if a doctor doesn't have information, right? Brent James was talking about this morning. You know, it's the variation, the knowledge of the variations between patients. Without that, you can't customize the treatment, right? So if information is a nutrient, we have these new capillaries carrying nutrients around that didn't exist before the web. This helps us understand what's different. And again, these people aren't surgeons. You know, they aren't oncologists, they aren't nurses, but they have access to information. And then finally, there's death by Googling. Oh, you're going to kill yourself. Well, a doctor named Eisenbach in Germany about 10 years ago wanted true stories of people who had died because they got stupid advice on the internet. He searched for 3 years and found zero cases of death by Googling. He did find people who had done stupid things, but nobody, not a single one, who had died from it. And being a man of intellectual integrity, he published it and said, we have overestimated the risks. Isn't that interesting? And the latest data from the Pew Internet Project, which you heard about earlier, says that people do go out and look for, more than half of American adults routinely look for information about anything from a hangnail to cancer. But before they do anything significant, they check with their trusted authority, the doctor. Okay, so what we have here is patients being engaged, right, and still it hasn't destroyed the trusted relationship. And now you compare that with the famous report that Brent James mentioned this morning about at least 100,000 accidental deaths per year, and Ferguson made this great point. It may be more dangerous not to Google your condition. What a thought that is. You know, the famous surgeon Atul Gawande that I mentioned earlier, I spoke on the same program with him in 2010 at Harvard, and he told the story of Dwayne Smith, a grocery clerk who had, was that a bell? Is my time up? No. Who had a horrible car crash. They put him back together as a medical miracle, but before he was discharged, they forgot to give him the 3 vaccines that every splenectomy patient should get. 2 years later, he was on vacation. He picked up one of the bugs that those vaccines would have protected against. He survived, but he lost all his fingers and toes, so he now lives the rest of his life that way. And Gawande's point, he just draws these great contrasts between the best and the worst of medicine. And when my turn to speak came 2 hours later, I said, so what if Dwayne's family had Googled splenectomy? They might not have understood everything, but they might have been able to say, wasn't he supposed to get some vaccines? Even better yet, what some people are doing now is they're sharing the whole care plan with the family and letting the family follow along like a checklist. Now, you've got to be not afraid to have a mistake pointed out in order to do this. But like Richard Rockefeller said, if you can view it collegially. See, we live in a world where we have this unrealistic expectations that doctors and nurses are supposed to do everything perfectly, even though they don't work in a system that guarantees that. You know, Dennis Quaid's twins were almost killed a few years ago, newborn twins, when they were given a dose of heparin 1,000 times too strong, and it turns out that, you know, the two bottles looked almost identical and they were in the same rack of the medication tray. You know, you can't take my American power cord and plug it into an outlet in Switzerland and cause an explosion or sparks or whatever, because the systems are engineered that way, but doctors don't work that way. It's valid to learn what the treatment should be. And he said these conclusions are no more anti-doctor than Galileo was anti-astronomer. Patients can simply do more than in the past. Can you see why it's important to view patients as partners, whether you're a patient yourself or whether you're a clinician? Right, the most underused resource. Lucian Englund, the guy who came up with the Patients Included emblem, developed this in 2010. This is a sort of an abstract model. In the old days, above that line in the medical institution is where all knowledge and resources lived. And it was sort of medicine 1.0. It was one way. It went down to the humble supplicant, the patient below the line. Today, we are more like medicine 2.0, which is the name of Eisenbach's conference. The patient has moved closer in knowledge, and now sometimes information goes the other way, and what they anticipate is medicine 3.0 and beyond, where we all understand that we're all swimming in a common pond of information. What this picture doesn't convey is that those circles aren't equivalent. There are surgeons, there are oncologists, there are family physicians, there are nurses, there are sisters who are really good caregivers like mine, and so on and so on and so on. Now, Tim O'Reilly is an internet guru who popularized the term Web 2.0. See, in Web 1.0, it was read-only. They could publish a brochure or a paper, but you couldn't comment, you couldn't write a blog yourself. Web 2.0 was when it became possible for you to write stuff there. And he said, when the web began to harness the intelligence of its users, and that's what's beginning to happen in medicine, okay? Beginning to harness the intelligence of the users. Now, if you've ever read restaurant reviews on Yelp or something, you know that it also harnesses the stupidity of its users. This place sucks. You know, and that happens in medicine also. So we got to learn to be intelligent. But now, what we now know is that that network diagram is attached to that patient. So it's not that the patient has necessarily become more intelligent, but has access to a network, and in fact, all the way around that circle, that's what's happening. Medicine is becoming a network of networks. And if we understand this and can learn to use it, go looking for information, and still be smart about what we harness. Now, I get lots of objections to this idea. My patients aren't like that. They aren't asking for this. Well, so this is culture change, ladies and gentlemen. Culture change, like the civil rights movement, the women's movement, gay rights. For your consideration, I give you a flyer that was posted by a friend on Facebook on Election Day last November in the US. Vote no on women's suffrage. It was from 100 years earlier. There was this crazy idea that women should be allowed to vote. And the reasoning on this flyer is just priceless. Let me enlarge the first bullet. 90% of women either don't want it or don't care. Oh, that's a real good reason to not let them vote. It's because they're not asking for it yet. Do I see parallels here? And just to show how brilliant the thinking was here, the next bullet said 80% of the women eligible are married, so they could only double or cancel their husband's votes. But when culture is changing, all right, when culture is changing, people go through cognitive dissonance. They see something happening, they say, that doesn't fit. So I got to come up with a rationalization, and sometimes they come up with crazy thoughts, okay? This is why it's important to think about what is valuable. Access to information is valuable. It's possible today for medicine, for patients to have access to valuable information. And Dr. Sand says, how can patients participate if they can't see what I see? Right? How can they be a partner in this if they can't see the medical record? So he is all for. In fact, my hospital participated in a big famous study that was published last fall called Open Notes, where patients get to actually see what the doctor wrote in the visit notes. And there were all kinds of concerns about this. The doctor's office will be flooded with stupid questions like, why did you call me an SOB? Well, no, SOB means shortness of breath, right? And what the study showed is that in reality, there was almost no difference. All right, now there are isolated stories like this that circulate like crazy, but there was almost no difference in email or call volume over the course of a full year. So my hospital now has decided to go with open visit notes, unedited, raw doctor speak for every specialty in the hospital. This is the world that's beginning. If you are a patient, a family advisor, whatever, and you want to be involved, start asking so that other people don't say, well, my patients aren't asking for it, right? Speak up, express yourself. People perform better when they're informed better. As Dr. James said this morning, if you know the differences about the individual patient, you can make better decisions. If you don't, you can't. And it turns out it applies to patients too. If I don't know what my numbers are or anything like that, I'm going to be ignorant. And then they say, well, patients don't understand this stuff, as I said. And there's a corollary here. It's perverse to keep people in the dark and then call them stupid, right? Well, we can't show you this, and by the way, patients don't know anything. That's how it works out. Well, so my feeling is if the data is unclear, you know what we do in every other industry? You got to make it clear. Last typesetting machine company I worked for, we had an incredibly powerful new system that was just way too hard for anybody to use, and the engineering department actually went to a board meeting and said, our problem is that marketing can't find customers who are smart enough. Now, we laugh about that today because we know on any website that we don't understand, we're out of there in a few seconds, right? But still, we tend to say, so here's an example. Thomas Getz, the editor of Wired magazine, got some blood work done, and this is the report he got. It's blurred out on purpose. And he realized, you know what? This is what my financial reports used to look like 30 years ago, rows of dumb numbers. And back then, investment advisors said, well, consumers can't understand this stuff. Well, you know what? And by the way, that's why you need financial advisors. Well, today, investment companies compete based on how pretty their graphic software is, right? So you can see what's happening with your money. So he went to his art department, which he can do because he's the editor of Wired, and said, can you make this look like an investment report? And here's what they came back with. Red for bad value, green for good value, here's where you are. Red for bad, green for good, here's where you are. At the top, your results at a glance. Son of a gun. Now look at this, okay? The same data displayed with better software, and all of a sudden the information buried in the data is clearer, and the same slacker consumer all of a sudden can understand. All right? This is consumerism starting to come to medicine. And as the data gets out from behind the hospital walls, innovators can say, ooh, I can make your kids' data look much prettier, and I can give you better immunization alerts for your children and things like that. Here's another great example. The very first keynote speech I gave in 2009, I was trying to figure out what is the psoas muscle. You might recall that I said that I had a tumor sticking out the back of my kidney that was almost attached to a big muscle. Well, it was the psoas muscle, which I'd never heard of. So I found this website, Visible Body, where you can't do this for free anymore. But I said, oh, that's the psoas muscle. I can see how a tumor coming out of the kidney would touch on that. And I was rotating it in 3D, right? Modern, snazzy software. And I had this epiphany, holy crap, you know, where I come from in high tech, you take one piece of software and combine it with a piece of data that came from somewhere else, and you do what they call mashups, right? Well, so I thought, what if we could mash that up with my digital CAT scan data, and I could have Google Earth for my body. I could be flying around through my body looking at my actual tumors and things, instead of having the doctor's generic physical model of stuff, of a heart on the desk and things like that. Well, last summer, I got a Mac, and I mention that because this software that I'm going to talk about only works on the Mac or the Linux operating system. And because I have copies of all my CDs, as you heard earlier, my scanned CDs. So I pulled one up. I needed to get a new slide for a talk, and I found this image. You know, and a CT or an MRI is like slices of the salami, right? So I was looking through this stuff, and I noticed in this software that there was a thing that said 3D viewer. And I said, what the heck is that? You know, I've worked with computer graphics for long enough to know that no free software could do 3D viewing. Well, I clicked it, and guess what? It put the slices of the salami together. That's my ribs and my tumor floating in there. That's the tumor. That red spot is the tumor that showed up in my lucky shoulder x-ray. And I'm rotating this thing, and wow. And then I noticed that there was a slider. I slid it, and it put the meat on my bones all the way out and showed my skin. And I thought, I'm glad I'm looking at this part. Well, be careful who's in the room when you're looking at this. And I slid it out further, and it showed my shirt. It showed that I had a piece of paper in my pocket on that day. Holy cow, who knew that this information was buried in that cryptic data? But that's the point. As we get innovators making customer-friendly, consumer-friendly, patient-friendly software, we will be able to understand things that were beyond our reach. And that's the new world. This software, by the way, people always ask, is OSIRIX. It's open source and free. There is a $1,000 professional edition, but this is free for Macs and Linux. Well, Dr. Eric Topol is a world-famous cardiologist, and he's an interesting guy because he says, you know what? The stethoscope may be a little bit, maybe getting close to being obsolete, because we listen to a stethoscope in order to imagine what's happening, how the valves are moving in the heart, right, without cutting the patient open. And he now has there's this handheld ultrasound called, I think it's a V-scan, and some medical students are being given one to carry in their pocket along with their first stethoscope, and they can actually just look at, on this handheld thing, the patient's valves moving. Well, there's a new thing called an Alivecor. This thing, those two electrodes, you put your fingers on it, and it gives you an EKG. Well, the trick is, it's an iPhone case. It was released by the FDA, approved by the FDA in December, and it's available for sale in Europe without a prescription. Of course, in the US, I don't know about the Canada situation, but in the US, you have to have the doctor's prescription to get one. Yes, an iPhone EKG that is sufficiently useful. Well, a month ago, Dr. Topol left the big Health IT conference in New Orleans and headed home on the plane, and they said, is there a doctor on the plane? A woman was having some sort of symptom. So he went and didn't just physically examine her. He got out his Alivecor and established that she was having atrial fibrillation. There was no need to put the plane down because she had a history of atrial fibrillation. And the world you want to think about that is not far away is a world where she has her history on her phone, so you can interpret the current reading in light of her history. This is Kaman, folks. This is the new world. All the medical brilliance, the diagnostic expertise, the intuition gained from clinical experience is not going away, but there are new tools available, making it possible for doctors, for clinicians, and patients and families to understand things that they couldn't before. I have an essay in the current issue of the British Medical Journal that goes to a deeper level. I'll only briefly touch on this. Who gets to say what value is in the first place? You know, what is value and who provides it? The doctor who screwed my leg back together certainly provided value. The oncologist, the diagnosis that came after the x-ray, all valuable. But on the other hand, my being engaged and informed created value too. Remember, the side effects of interleukin sometimes kill patients? Today, my oncologist said, you were really sick. And I don't know if you could have tolerated enough medicine if you hadn't been so informed. What he meant by that was to prepare myself for this drama, knowing that the treatment might kill me. I went looking for information about how to survive the side effects, and I found nothing on medical websites. So I turned to my patient peers, and they gave me 15 first-hand stories. One said it was no big deal. One said, I really thought I was dying. One woman said, my husband's skin flaking was terrible. I had to vacuum the house twice a day. I thought, how much skin does this guy have? I met her later at a speech. She said, that was me. Yeah, I'm a neatnik. Well, seriously, when the first side effect hit me and I started shaking uncontrollably, I knew it was Rigers. I knew you call the nurse, they bring warm blankets, you warm up, you keep shaking for a half an hour, and then it's over. Time after time. My oncologist says that being engaged and informed may have contributed to my being alive today. Is that a motivation for, number one, doing it yourself if you're a patient, and number two, letting patients help if you're a clinician? And I'm going to wrap up now. You know it's a revolution when the artists and musicians show up. And in fact, in this TED Talk that I did 2 years ago, I was nervous backstage, and I said to the host, I said, you know, there's this guy named Keith Boone outside Boston who wrote an e-patient rap. And he said, what's it like? And I said, oh, I want to be an e-patient just like Dave. Give me my damn data because it's my life to save. And he said, oh, you have to do that. I said, no, I'm not going to do that. I'm not going to do something impromptu. He said, you have to do that. I said, but if you're going to rap, you have to have shades. And the MC pulled her shades out of her pocket, and they fit. So I did it. What's interesting about this video, though, all right, what's interesting about this video is that within 2 months of it going live on TED.com, this sort of Speakers Olympics website, it had been watched so much, not because of the rap, because the rap is way more than halfway into it, been watched so much that it rose to the top half of the most viewed TED Talks of all time, and it's continued to stay there. And the chant at the end of it is, let patients help, let patients help. And you've got to wonder what's going on. Not only that, but at the bottom, you can't see it in this framing here, but trained volunteers can add subtitles in various languages, and people have added subtitles to this in 26 languages. I would say that the clinicians who honestly believe that patients are disengaged, lazy slugs are missing out on something here. I mean, Korean, simplified Chinese, traditional Chinese, Croatian, you know, Farsi, Persian. Well, on the art side, there's a woman I know some of you know named Regina Holiday. She is a kidney cancer widow. They had been to 3 bad hospitals in Washington, D.C., and for her husband, it was too late. Eventually, she ran into a friend that she hadn't seen for a while and who said, oh no, kidney cancer. I know a guy on Twitter, which was me. And we talked that night. This is a painting she did of our first meeting on the phone. And within 24 hours, she was talking to my oncologist in Boston. Unfortunately, in her case, what he had to say was, sometimes it's too late. But she had connected, although too late. Well, she has turned her loss into advocacy. This is the artist, all right? She now has done many paintings. In fact, this is a meeting. She says people are walking around with medical stories and we just don't see them. She has now done over 200 jackets. People tell them her story and she writes that she paints them. It's called The Walking Gallery, and here she is meeting with Regina, the other Regina, now Regina Benjamin, the Surgeon General of the United States. And this guy, the guy in the blue shirt there, is a guy named Ross Martin. He has an obscure hobby. He writes songs about health IT. I'm not kidding. And he has a garage band, and one of the songs he wrote, there's a great video of it online. You can find it on my website, epatientdave.com. Anyway, it's a 1 for the doctor, a 2 for the nurse. She's saying you're trying to treat me so to make me feel worse. Give me my damn data. And it goes on and on and on for 4 minutes. It's an incredible video. What is this? Guy from Nashua, New Hampshire. People are writing a rap and a rock video. Well, finally, recognition from the establishment. Brent James was part of this last item before we close. The Institute of Medicine last September published a major new report, Best Care at Lower Cost. And in addition to many other things in its 382 pages, it said, we need a continuously learning healthcare system, and one of the 4 pillars is patient-clinician partnerships. The Institute of Medicine now says patient-clinician partnerships are essential to making healthcare work better. So I get to say, game over, people. Let's get to work. You know, people want to say, I'm not going to trust it till it comes from the medical establishment. Here we are. That's specifically anchored on patient needs and perspectives. Promotes the inclusion of patients, families, and other caregivers. Brent James was one of the authors of this report. It was a thrill for me to be able to meet him this morning. You know, so when you think about what is anchored on patient needs and perspectives, there's an IVF, an in vitro fertilization clinic in Holland, where they gave their patient community 6 months to discuss online, if you guys could have anything, patients, sharpen your pencils here, sharpen your want glands, all right? If you could have anything, what would it be? And now, I've been to this clinic, and It's not a happy place. You know, these are people who are there because their dreams are dying. They might not ever have a baby. And the first two things on the list were things that amounted to financial support for more attempts at fertilization. The third thing on the list, if they could have anything, was empathy. I don't want just information from my clinicians. I want them to empathize with my situation. The fourth is incredibly moving. Separate waiting rooms for families who've conceived, so that the ones who haven't don't have to be faced with it. You know? Are you thinking in terms of, if patients could have anything, what would they want? It's not necessarily all about more spending, more money. Ask. Here's how it all unfolded in my life. This is the photo of me from the night of that physical, or just before that physical, rather. Yeah, this was the New Year's Eve, the New Year's weekend when I went away. This is a guy who was dying of kidney cancer and didn't know it yet, but was about to find out. Well, 10 months later at the office Halloween party, I was very glad my treatment had ended. Somebody snapped this picture. There I was grinning at the ghoul. Shorter hair, a bit thinner, definitely better looking. I'd pictured my mother's face at my funeral, but instead here we were a couple years later in May of 2009 when I did get to walk my daughter down the aisle at her wedding. And boy, was that worth staying alive for. And at Christmas this year, she gave me a jigsaw puzzle, and this was the first part I could solve. Can't wait to meet you. And what was next to it was a big mess of black and gray lines. And here's a later ultrasound. My baby girl is pregnant. I'm going to be a grandfather. And man, new software tools. Have you heard of 4D ultrasound? I was surprised. I was one of the first people ever to have an ultrasound picture on his desk at work back in 1983. Well, 4D ultrasound, they have higher resolution ones, so they can do 3D ultrasounds. You put them together and you get a movie of the baby moving in utero. That's my granddaughter who's going to be born in July. She has her mother's nose. I love what is possible with all this software and new tools. Patients included, the key to a better future. Patients are the most underused resource. Let's be partners. Let's make great things happen. Thank you.